Hello, everyone, and welcome to Advancing Public Health Surveillance's Role in Tackling Health Inequalities, which is the second of the Surveillance Advances Seminar Series, co-hosted by the Public Health Agency of Canada and the National Collaborating Centre for Infectious Diseases, or NCCID. My name is Wendy Xie, and I'm a project manager at NCCID. I will be your moderator for today, along with Elisa Jiang, who is an acting senior epidemiologist in the Data, Surveillance, and Foresight branch of the Public Health Agency of Canada. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning, programs, and policies related to infectious diseases. We are incredibly pleased to be co-hosting the series with the agency. I would like to acknowledge that NCCID is hosted by the University of Manitoba on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. At NCCID, we strive to honor the lands and their original caretakers in our work. We acknowledge that we are on Treaty 1 land, and we recognize that this and other treaties have been implemented as a part of the process of colonization intended to benefit some while harming others. We are committed to working with our partners towards reconciliation. I am joining this event from the unceded lands of the Anishinaabe Algonquin Nation. So before we get into today's seminar, there are just a few housekeeping items I would like to mention. First, a recording of this seminar and the presentation slides will be available shortly after the seminar on the NCCID website, which is nccid.ca, under the webcasts tab. And the chat box for today has been disabled for participants. The hosts will use the chat box to communicate additional information with participants. But if you run into any technical issues with Zoom during the seminar, please email us at nccid@umanitoba.ca. At any point in the seminar, you can send us topic-related questions through the Q&A tab, and we will try to address as many as possible in the discussion period after the presentation. You can also like any of the questions to push them up in priority. So we would like to note that Surveillance Advances is a Section 1 self-approved group learning activity as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada. The seminar series is also approved by the Council of Professional Experience for Professional Development Hours for members of the Canadian Institute of Public Health Inspectors. If you require a letter of participation, please look out for the survey that will be shared after the seminar where you can make your request.
Thank you, Wendy, for covering some key housekeeping items. Welcome everyone to the second seminar of Surveillance Advances. Bienvenue à tous. While today's seminar will be delivered in English, we welcome everyone to post their questions in their language of work. I would like to take this time to acknowledge the land where I live and work, located on Treaty 1 territory, the traditional lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and on the homeland of the Métis Nation. We honor the Indigenous people who have lived on and cared for these lands for generations, and I am grateful for the opportunity to share and call this place home. Today, we have participants and presenters joining us from coast to coast to coast. The land in which they and you join us from represent the lived experience of many Indigenous peoples, all with their own unique health story. As a public health practitioner, I will continue to challenge my way of thinking and practice to ensure that the work that I do provides space and opportunities for Indigenous people to tell their stories, to highlight their strengths and successes. Furthermore, we would like to acknowledge that the practice of surveillance may raise concern for Indigenous people and other communities. To public health professionals, surveillance sounds similar to epidemiology, which is about understanding the distribution and patterns of the determinants of health and diseases in populations. But for others, surveillance may carry negative connotations about security, privacy, and control. For this seminar series, we would like to note that we use the word surveillance to refer to the assessment of and response to public health threats as a core function of our public health systems. This seminar series is not just about the speakers and organizers, it's about you, the audience. Your active participation, questions, and perspectives are vital to the success of this initiative. We encourage you to engage in discussion, ask questions, and share your thoughts and foster collaborations that can lead to improvements in public health surveillance. With excitement, I would now like to introduce and welcome our speaker for today's seminar. Dr. Arjuman Siddiqui is a renowned social epidemiologist, professor in Canada Research Chair in Population Health Equity at the University of Toronto's Della Lana School of Public Health. She holds various academic appointments, including sociology, public policy, and women and gender studies at the University of Toronto, along with adjunct professorships at Harvard University and the University of North Carolina, Chapel Hill. Dr. Siddiqui's research focuses on understanding health inequalities. In recognition of her contributions, she was awarded the 2022 Canadian Institutes of Health Research Institute of Population and Public Health Mid-Career Trailblazer Award. She earned her doctorate in social epidemiology from the Harvard T.H. Chan School of Public Health. Welcome, Dr. Siddiqui. We are happy to have you join us today, and we're excited to learn from you.
Elisa, thank you so much for that kind introduction to Wendy, and particularly to Jonathan, who has been lovely in organizing me for today, and to the whole team. Very much appreciate being here and being with you. So there's a bunch of learning objectives here. I don't know, Elisa, if you want me to speak to them at all. Is it worth kind of going through them? I guess I'll do that just in case it's helpful to people. So this seminar, by the end of it, we're hoping that you will be able to describe the relationships between public health surveillance, health inequalities, and population health, to understand Canadian and international examples, particularly US examples, that demonstrate how monitoring and assessment of health inequalities informs public health action, and to understand contemporary trends in health inequalities, their likely causes, and how they drive the future of public health surveillance. Next slide, please. Thanks. Next slide, please. Thanks. So the first a statement out the gate is a little bit of a sort of strong one. And that is that at some level, overall population health and health inequalities are really the same thing, or very closely related at the very least. Next slide, please. We've been doing work to compare Canada and the US for a long time. And on the left is a graph of life expectancy in both countries. So the top line is Canada in the blue, and the bottom line is the US. And what you notice, particularly after about 1980, is that this gap opens up, whereby Canada maintains an advantage over the US in life expectancy. And I'm happy to go through why we think that's the case in detail in the Q&A. But I think from the surveillance perspective, and from a sort of empirics of the underlying data perspective, what we think might be happening is that those health differences overall, so overall life expectancy, are very related to the fact that the two countries have very different levels of health inequalities across the population. So on the right-hand side in the top graph is a demonstration of differences in the prevalence ratios of obesity in each income quintile in both countries. So on the left are the sets of bars for the US, and on the right for Canada. And there's two things to notice. One is certainly Canada has lower overall obesity across all income brackets, but it's also the case that inequalities are much more muted in Canada. They exist, and for other outcomes, they're much more pronounced. But you can see that in the US, the difference between the lowest and the highest income quintile and the proportion of obesity is much more pronounced. In the bottom right-hand side is a graph from a study we did looking at racial health inequities in a variety of outcomes, and this one is hypertension. And you see a similar story, which is that both the US in blue and Canada in red have racial disparities in hypertension. The first bar is Black hypertension compared to white hypertension, but that Canada's health inequalities seem to be a bit more muted. Racial health inequalities seem to be a bit more muted than in the US. So putting these pieces together, we have a sense that in places that have lower overall population health, part of the story is that the inequalities in population health are actually more muted than in others. Next slide, please. And if you look at this conceptual framework, which is the World Health Organization framework on social determinants of health, you can see why that might be the case. So if you start on the right-hand side, there are health outcomes that are produced by a set of mechanisms. And those mechanisms include income, behaviors, stress processes, and all the kind of various kinds of things that affect health, and that those are produced or at least distributed by social determinants, things like your socioeconomic position, your income, your education, and so on, your gender, your race, ethnicity, etc. And on the left-hand side, there's a sort of presence of societal conditions, social policies, and other kinds of ambient conditions in societies that kind of drive this whole mechanism. In other words, there's no necessary link between income or race and health behaviors or stress or what have you and health. Instead, it's the fact that our societies kind of set up in ways that create these inequalities. And effectively, what we're saying here is that this is a framework that not only explains inequalities in health, it also just explains overall population health. This is how health works. Health is the consequence of a bunch of sort of downstream individual behavioral stress and other mechanisms, but that is fundamentally patterned in populations across social and economic groups. And so at once, this is explaining both health inequalities and overall population health. And that's part of the reason we think they are so closely associated. Next slide, please. This is a graph of the racial distribution of COVID, at least early on in the pandemic, and it was true later on as well. And in the green bars are the share of the Toronto population by each racial group. And in the gray bars are the share of COVID cases for each racial group. And you can see from the gray bars compared to the green bars that many non-white groups, most non-white groups, were overrepresented in terms of COVID cases as a proportion of their population, whereas whites were underrepresented. And at the same time that this shows inequities, racial inequities in COVID cases, the proportion of cases that were accounted for by non-whites in Toronto was upwards of 75%. And that means that overall population health was also socially distributed. So this is both an inequities issue, but also an overall population health issue. Next slide, please. So one kind of issue is this idea that if you look at inequalities, they may tell you something about overall population health in addition to telling you about the inequality itself. But what I think is important from a surveillance perspective is that if we routinely monitor these health inequalities, we can start to understand what changes them. What are the conditions in societies that make inequalities get worse or get better? Next slide, please. And we have examples of this from the United States. This is a study by Nancy Krieger and colleagues who have a project in which they do routine monitoring of cancer-related inequalities by race and by income. And I think you can't probably see the details of this very well, but just to give you a sense, on the left-hand side is kind of the raw description of cancer rates by income and by race over time. And you can see that they're not consistent, that inequalities change over time. And that gives us information about what may cause that change. And on the right is a sort of more sophisticated analysis of how things changed over time. Nancy Krieger and colleagues often favor something called join point regression, which kind of puts a bit more statistical nuance to the raw descriptor graph on the left. Next slide, please. This is another example of some kind of monitoring work that was done. This is I don't know if they would call this monitoring work, but it's kind of 6 of one and half a dozen of the other, because it does demonstrate COVID cases and COVID deaths they've done as well, across neighborhoods that have different levels of crowded housing, which you can imagine is a socioeconomic indicator, and one that was particularly significant during the COVID period. And so what they have is each line representing a set of neighborhoods that have a particular level of crowded housing, a particular proportion of the population living in crowded housing. And so you can see that over time, unsurprisingly, that COVID deaths and COVID cases have risen over time, and that they are worse in areas that have more crowded housing. Next slide, please. So if you put that together and you say, okay, well, overall population health is likely very tied to socioeconomic inequalities in health, and that monitoring over time would give us information about how socioeconomic health inequalities are moved, are changed over time, what causes that. There's a bunch of sort of specifics that you can imagine we could have learned if we engaged in some of this routine monitoring. Next slide, please. So again, on the left is racial inequalities in COVID cases in Toronto at a point in time. On the right is the Krieger graph that shows economic and racial inequalities in cancer changing over time. So imagine if in Toronto we were able to monitor racial inequalities over time to determine whether they changed during the COVID period, what caused them to change, and so on. For example, we may want to know, did they improve or not after the availability of vaccines? How quick did that happen? Did it not happen? Et cetera, et cetera. Next slide, please. This is a graph taken from Public Health Ontario, in which they do effectively a surveillance activity, which is to look at the number of tests completed in different age groups amongst children and adolescents. And so you can see the lines across time that represent different age groups. And on that, they have superimposed different critical moments in the lives of children, when schools opened or closed as COVID precautions and so on. And so the idea is that you are superimposing events that happen in society over the trends of socioeconomic inequalities, and that helps to see whether overall population-wide interventions are effective for all socioeconomic groups equally or not, and so on. Next slide, please. Let me give you also a few examples, not of what we could have learned, but what we are learning by taking up some of these activities. Next slide, please. This is a graph or a set of graphs that shows changes in life expectancy over time. The left-hand side are the US, women on the top, men on the bottom, and the right-hand side is Canada, women on the top, men on the bottom. And what you see over time in the US is that life expectancy has gone up, but has gone up much more for high income groups, so that inequality is actually widening, not because you see a decline in life expectancy or a pronounced one, at least till 2015, but because the gains in life expectancy are disproportionately going to high income groups. So this calls into question several things. For example, what is the basis of our concern for inequality? If it really is the unjustness of unequal health status across social groups, as it should be, then we should be concerned even when all groups are gaining, because they're not gaining equally. They're not all sharing in health prosperity equally. But it also tells us that there doesn't appear to be anything across those groups that is significantly worsening life expectancy over time. So you get this kind of information only by routinely monitoring and evaluating what's happening. A similar story is showing up in Canada, and arguably, the gains at the high end are even more pronounced, or the inequality is even more pronounced than in the US, but we could sort of quibble about that. But in general, what we're seeing across these high income countries is that gains in life expectancy are not being equally shared across groups. Next slide, please. So one question that comes up, if you go back to how health works, which is what I think this framework shows up, is why is that the case? Why are we seeing gains for high income groups compared to low income groups? And not only seeing them, but again, this is about gains. It's not about the fact that you have inequality. It's about the fact that inequality is changing over time. So the question is, why are those gains going to the high income groups as opposed to the low income groups? And we have some ideas, and again, I can talk about that in the Q&A if that's of interest, but it's a very different question than how we usually think about health inequalities, which is or do we have them? Are there health inequalities between social groups? This is about what's happening to them over time. Again, it's a sort of surveillance and monitoring question. Next slide, please. We did a paper a while back. This is from my former doctoral student who is extremely brilliant about all of this stuff. And he did a study where he looked at health inequalities between employed and unemployed Canadians. Next slide, please. And so he asked the question, what does the self-rated health look like for employed Canadians compared to unemployed Canadians? And this is a graph that shows the prevalence of people in either group who report poor self-rated health. And the bottom sort of a darker dashed line is the prevalence of employed people reporting poor self-rated health over time. And the lighter lines are the confidence interval. In the top line, the solid black thicker line is the proportion of people reporting poor self-rated health amongst the unemployed. And again, the confidence intervals around that. And so what we found over time is that the self-rated health of employed people doesn't seem to be moving that much. It's not changing. But for unemployed people, it's getting worse, meaning that from 2000 to 2014, there was a rise in unemployed people reporting poor self-rated health. And so now that's the sort of monitoring surveillance question. And then the question is, why is that happening? Next slide, please. So sorry, I forgot this part. So the exact numbers here. So between 2000 and 2014, it was an increase of about 4% in the proportion of unemployed people reporting poor health, and again, stable for employed people. Next slide, please. So we decided that what we wanted to know is why this is happening, what characteristics of individuals could have changed over this period to induce worse health for the unemployed. So yes, we're not surprised that unemployed people have worse health than employed people, but why is it the case that that's actually getting worse over time? So we first started with the set of individual variables that might change, demographic variables. Maybe unemployed people were getting older, and so older people have poor self-rated health. Maybe the sex gender distribution is changing, and that can affect poor self-rated health. Marital status, immigrant status, et cetera, socioeconomics, education, homeownership, income. We know very well that economic conditions for poorer people have declined over time, that median income has declined in many moments during this period. And so maybe it's that the socioeconomic conditions of unemployed people have worsened over time. Maybe part of this is also because of those socioeconomic conditions, that their stress, their chronic conditions, hypertension, obesity, smoking, binge drinking, and physical inactivity has gotten worse over time. So effectively, we were using that WHO conceptual framework to ask the question of the determinants of health that we have access to in terms of Canadian Community Health Survey data, which is the data we used. Which of those, or are all of them worsening over time? And is that why unemployed people's health is worsening over time? So we used a technique called decomposition, which allows you to ask the question, what proportion of the difference between two groups is accounted for by the variables that you enter into the model? So instead of modeling the difference between employed and unemployed people, since the employed line was constant, we modeled the difference between unemployed people in 2014 and unemployed people in 2000. Next slide, please. And these are the results. So you can see that the total kind of gap in unemployed people reporting poor self-rated health is in the order of 4%. And in that line that says explained, that suggests that all those variables I just mentioned explain only 13% of that 3.8% difference. Meaning of the 3.8%, we've only explained about 0.5% of that, leaving us with 3.3% of the story unexplained, having used all the variables we typically use to explain inequality at a given point in time. And so effectively, that's telling us that our data is not very well equipped to explain inequality over time, even when it's equipped to explain inequality at a given point in time. Next slide, please. So the sort of gist of the matter, again, is that unemployment-related health inequalities do not seem to be explained by individual characteristics of the unemployed. It's not the fact that those may have been changing that explains worse health. We aren't sure why, but we have a couple of reasonable guesses. One is that there has been a change in the significance of many of these variables. So even unemployment and the significance of what it means to be unemployed and what life looks like when you're unemployed has changed. So for any given category, the context of that category, be it income, be it unemployment, the meaning and the context have changed over time. And so effectively, you're not necessarily measuring what you need to be measuring when you measure it crudely with those variables. And so one strong possibility is that there is a set of societal dynamics that are changing the meaning of the life of the unemployed and the life of the poor in ways that we aren't able to capture with our routine variables. But it's very challenging to know how to test this. One possibility is that you look over time when you surveil these things, you look to see where there are significant changes and backtrack again into whether those correspond to particular policy changes, particular event changes, and that can start to give you a sense more than our study, which looked just at individual level determinants. Next slide, please. So again, if you come back to this framework, just to reiterate, what we're saying is that the variables on the right-hand side did not explain why unemployment and its effects on poor self-rated health changed over time. We suspect that is because on the left-hand side, the conditions of society changed so much that they weren't predicting this pattern in the same way that you would sort of in cross-section. Next slide, please. This is a graphic from Toronto Public Health. And it kind of gives a similar story. I just thought I'd point this out from a surveillance perspective, but also sort of how to get perspective on these things sort of story. So in 2005, Toronto Public Health set out to measure income-related health inequalities in Toronto. And it found, not surprisingly, that there were income-related health inequalities across a broad range of outcomes. And you can see them here, everything from gonorrhea, physical activity, diabetes, et cetera, life expectancy, low birth weight, and on and on. And Toronto Public Health decided that it wanted to do something about these health inequalities. So it put together a bunch of programs to address them. And I don't know the sort of exhaustive list of what they did, but they were mostly things like educational and support programs to, encourage healthy behaviors. I think they offered subway tokens so that people could get to the programs without any cost and so on. And then they went back in 2015 and remeasured health inequalities across income groups. And as you see on this slide, 21 of 34 health indicators got worse over the time that Toronto Public Health tried to address health inequalities. Next slide, please. We, again, aren't sure why this happened, but our best guess is that the upstream factors which declined over this period, decline in median income, worsening of housing affordability, more job insecurity and precarious employment, those factors that worsened over that period simply swamped out anything that a downstream education program could do to address health inequalities. And again, it's really important from a surveillance perspective to know how things are changing for inequalities over time, and then to be able to say, okay, if this is the point at which we implement a certain program, do we see things changing? Conversely, can we map on some relevant moments in time, policy changes, program changes, to see if they change health inequalities? Next slide, please. So at this point, I'm totally happy to take any questions sort of that would be helpful to the group. Thanks very much.
Thank you, Dr. Siddiqui, for your insightful presentation on public health surveillance and health inequalities. We will now have a Q&A discussion period with Dr. Siddiqui. We invite everyone to ask any questions you have for Dr. Siddiqui using the Q&A tab. Everyone is welcome to participate in the conversation. We will try to answer as many questions as possible, but we may not get to all of your questions. But first, we'd like to share some initial discussion points for Dr. Siddiqui just to kick things off, if that's okay with you. I think many will agree that the COVID-19 pandemic played an important role in uncovering and magnifying health inequalities that have existed within societies and between different population groups. Dr. Siddiqui, in your opinion, what would it have meant to adequately monitor health inequalities from the start of the COVID-19 pandemic?
Yeah, thanks so much. I mean, I think it would have been critical because I think we treated health inequalities as if they were something that just surprisingly turned out to be the case as the pandemic quickly progressed, when in fact we should have known from the start that because health, unfortunately, is patterned this way because we haven't done anything to change the societal conditions that make it so, we should have anticipated this from the start. And if we had collected data from the start, we would know this. In fact, if we were in the business of routinely collecting and monitoring a variety of different health inequities, not just COVID, but just having that be a routine part of what we do, then we wouldn't be caught so sort of flat-footed about this. I think that hopefully would have alerted us to what some of the fundamental causes were of disease transmission. So again, on the one hand, the fact that there were racial inequities in COVID that were so pronounced told us something about an unjust feature of COVID and of the COVID pandemic. On the other hand, it's impossible to understand the transmission of COVID without understanding the issues of race, racial capitalism, and the distribution of essential service work. Because that's essentially what happened, is that a bunch of people stayed home who had the jobs that enabled them to do so, like probably most of us on this line. And a lot of people had to keep working and going into dangerous workspaces. And those people were disproportionately racial minorities because of a range of societal conditions that induce that phenomenon. So yes, this is about inequalities, but it's also about understanding the link to the overall phenomenon, and collecting data from the start would have been absolutely critical.
Thank you, Dr. Siddiqui. Just in that same line of thought, are there examples of health inequity data that we should be collecting that we aren't currently collecting? Whether that's applied to COVID-19 or something different in terms of the health stream. Is there examples that you could maybe share?
Sorry, of data?
Mm-hmm.
In my mind, the way to think about this is to think about the way society fundamentally is structured and stratified. So what are the axes that are the most important for determining what your life exposures and life chances are? And that tends to be your race and your social class. And that tends to be the case in all high income immigrant receiving colonized countries with a history of colonialism. And so for me, not having routine access to information on class and race really puts us behind the 8 ball for trying to understand how inequities play out, and again, how population health is playing out.
And this is my last question from our end. But Dr. Siddiqui, what are the most pressing health inequalities and disparities that need immediate attention in Canada? And what strategies can be applied to address them?
So part of the issue with health inequalities is that at any given time, there may be a different outcome that appears to be the most pressing. Things like infant mortality, birth weight, adult mortality, life expectancy. The ones that rise to the top may vary over time. But I think the issue is that all of them are very interrelated by virtue of the fact that they are all produced by upstream factors, which cause a range of downstream mechanisms which lead to different health outcomes. And in fact, the sort of fundamental lesson of COVID is that if you don't change what happens upstream, those social factors will reassert themselves through a different mechanism and a different disease. It doesn't matter what it is. So even before we knew what COVID was and how it was transmitted, we had racial health inequalities and socioeconomic health inequalities in COVID. Why? Because that's fundamentally what we do in society. We offload risk to the most disadvantaged. So I can tell you an outcome here and an outcome there, but I think that's the wrong way to look at it. I think the issue is, even if you solve some health inequality in some outcome, you will find another one. And what we know of the literature is that there's health inequalities in virtually every health outcome of which we know. So working from the end of what can we do about any particular one, or what is the worst one, is probably not as an effective strategy as coalition building across them and understanding the relationships across them.
Thank you for your thoughtful responses, Dr. Siddiqui. I'm going to pass it over to my co-moderator, Wendy, to take on some of the audience questions from the Q&A section. Thanks.
Thank you, Lisa, and thank you, Arjumand, for that excellent presentation. So we do have quite a lot of questions in the Q&A tab, and I will be going based off of the most upvoted. So our first question is from Rebecca, and Rebecca is wondering, what are the opportunities to measure or include in our models how experiences of colonialism, racism, etc., might be reflected in the upstream socioeconomic and political contexts. That is there a way to examine if these factors explain some of the proportion of differences between groups?
Yeah, it's a great question. So I'm going to give you sort of three answers, and I'm just going to take liberty as the speaker to say, I think I see Rebecca Hastel in the Q&A, and Rebecca, I've been trying to get a hold of you. So if you can email me, that would be great. So there's three answers. One is that there are particular ways, mostly econometric strategies, that we use to judge whether a policy or some structural condition has had an effect on health or on any outcome. So often we use what are known as quasi-experimental designs, things like difference in differences and so on, to understand whether a group that was policy exposed has a different outcome trajectory than a group that was policy unexposed, meaning did the policy induce a change in the group that was exposed to the policy that we can attribute to the policy. So it's very much set up like a randomized control trial. So when you have what we consider to be sort of a policy shock, for any economist on the line, an exogenous shock of some kind, a recession that happens suddenly, a sudden policy change, we, in theory, given data over time, before and after the change takes place, can construct a study designed to understand what the effect of that structural factor was. There's a second part of this, which is that sometimes what the societal conditions are that are inducing these changes are not sudden shocks. They're not one policy. And that becomes more challenging in an epidemiological framework to assess. And I think the conversation that many of us are having is that if it's the case that epidemiological methods and even econometric methods are not great for assessing many of the societal conditions that are important, then we should think about whether there's a broader toolbox rather than having those, limiting ourselves to questions that we can ask with our tools. If there are important questions we aren't asking, which there are, which are these kind of broad, diffuse societal conditions, structural racism, histories of colonialism, racial capitalism, those are not things that we can easily capture with our tools, then we should really think about what we need to do as scholars and as scientists and as public health officials to make sure that we include those, because they aren't incidental. Those are sort of the meat of what's happening. The third is to give the example of structural racism. So there is a very active discourse in epidemiology right now on how to measure structural racism. So the idea is that for a long time, in the US in particular, we've been measuring racial health inequalities. We even got to a point that we're measuring experiences of discrimination, but the argument has been these still don't quite address the structural forms of racism, the ones that are institutional and so on, that are probably the biggest problems for health. And so there's been different kinds of suggestions about how to do this. And often the recommendation is to use some kind of set of measures that essentially document how unequal particular social and economic conditions are across racial groups. So for example, there's a paper that says its goal is to examine structural racism in relation to birth weight across New York counties. And their measure of structural racism is ratios of unemployment and So and ratios of other things, I think median income. So Black unemployment compared to white unemployment. So County A has a ratio of Black to white unemployment, or a difference that is, let's say, in the order of 4%. And another county has one that's in the order of 5%. And so they're correlating effectively that metric of the structural feature of the county, meaning that that unemployment ratio tells us something about the conditions, the structural conditions under which Black people are living compared to white people. And you can then correlate that metric with health outcomes. Now, that's not without its problems. So in the first place, it presumes that that structural racism can be measured continuously. It presumes that county level metrics are a good measure of structural racism. So there's an ongoing back and forth about how to do this. I think we've pretty well nailed or done very well in understanding how to measure structural conditions that can be framed as sudden changes, because we have a set of methods that accompany that. But the other big structural, historical, diffuse stuff, I think we're still grappling with how to do that.
Thank you so much. So our next question, which I am also very interested in, a participant is asking if you could speak to the participation of communities in ethno-racial data governance.
I am not the best person to speak to this. I don't know that much about data governance. It's not my expertise. I think I sense that that's a major kind of consideration in Canada. And by all means, I think that conversation should go ahead. I was trained in the US where racial data is available as a matter of course. There aren't the same extent of conversations happening about governance. People generally want data to be out there so that scientists like me can readily use it and produce evidence with it. That's not to say bad things don't happen, but I think the thinking is that on balance, the amount of knowledge that we can produce is when things are routinely collected and available is really, really valuable. So if you look at the volume of work that is done in the US on racial inequalities in all sorts of outcomes, it is a night and day difference from here. And that's because race data is routinely collected and extremely accessible. You can download it off the internet. You can download national data off the internet and research it. And so I sense that the stakes and the discussion in Canada are very different about those dynamics. And again, because I'm not an expert, I try not to wade in too far, except to say that I think we really run a huge risk when we lock down important data about how our society works.
Thank you so much. Maybe that's a great point to address in a future seminar. So our next question from Monica. First, Monica would like to thank you for such a wonderful and informative presentation. It is not lost on me that there has been a much larger shift to understand health inequalities in more recent years, even though this important work is not new. You've emphasized the importance of routine monitoring, but my question is around quality of data. Racial inequities are not new, but some organizations have just started to collect this information or have started to examine whether the data is really measuring what they want to measure. Do you have any recommendations as to how organizations can maximize use of historical data? For example, a survey and administrative data that may not be of the same quality as data that has been collected in more recent years.
Thanks for that question. To be honest, I don't know of that much data out there that is historic or, that there's this sort of large kind of variation, because I just get the impression there's not that much data out there, period. We did a sort of audit of the data available from StatsCan to look at racial health inequalities, and it was fairly limited. And for the most part, the data that's available now is either from surveys, which are not that historic, at least the ones that we were able to see. And the administrative data that is available is usually the stuff that is linked to the long form census. And generally speaking, what we saw is that it's pretty similar. They ask you a question about your race, and we can definitely argue about whether the categories make sense or not. There's one Black category and 10 Asian categories and so on, and we can talk about what that means. But by and large, my sense is that it's self-reported race, which is totally standard in the literature. Again, race measured in different ways can mean different things. And I'll stipulate to that, but it's also the case that the degree of misclassification or issues is minimal compared to what you get, the amount of data you can get by doing what is the easiest, which is to ask people how they self-identify. So all that to say, I don't really know that we have a more quality and less quality issue. Maybe we do, and please feel free to email me. I'm happy to hear about that. I just think we have a not enough data issue and not routinely collected issue. Like even COVID, it took a while for Ontario to get on board. And Toronto just kind of started when Ontario initially refused to collect race data, but it was just for COVID. I mean, so I feel like that's the biggest kind of issue.
Thank you. So next question, super quickly, can you speak to the language used between health inequalities versus health inequities? Is there a technical difference?
There is. Again, we can talk about what the differences are. The basic idea is that inequalities are just a sort of empirical descriptor to say that there are differences in health between social groups, or between any two groups, really. An inequality could be any two groups. Inequity is when that difference is unjust. It can be attributed to an injustice. And so I know there's a lot of discourse that says, well, we should always use the language of health inequities because any difference between racial groups or socioeconomic groups is unjust. And therefore, it's not only an inequality, it's an inequity. The flip side of that is that if you say there are racial health inequalities or socioeconomic health inequalities, it's hard to imagine that you mean anything else or that you should mean anything else besides the fact that it's an unjust difference. And I don't sense that in the literature, it's creating much difference in how things are done. So yeah, okay. I'll agree to the fact that maybe we should all call them inequities, but on the ground, this is not really making a big difference. Some of the best inequity scholars call them inequalities. It's not a big deal. As long as we understand that there is a big injustice component.
Yes, of course. Thank you so much. Our next question is, how do you think we can adjust our surveillance or investigation strategies to better see and understand those upstream factors and the systems in which they exist? And I would like to add to that, maybe provide a couple of your thoughts and perspectives on how to bridge the gap between data collection, research, and implementation in policy.
Sure. So I don't know if I'm going to offer a lot of insight because I frankly don't know enough about Canadian surveillance systems to speak really well on what you should be doing. And I can only say as a scientist that I find the data lacking and the data access brutal. I mean, having to go to a data center and, all the rules around that, it just is like the barriers to actually routinely doing this stuff are way higher than they are in other countries. So, just to give you an example, my team and I did a project for the government of Ontario where we looked at the relationship between employment insurance and health. And we decided we would look at Ontario, we would look at all of Canada, and we would compare it to a couple of peer countries, the US and the UK. And sitting in Ontario, it was much more difficult to access and use the Ontario and Canada data than it was the US and the UK data. Sitting here, that's just a brutal problem. I mean, I think if Canada can figure out how to jumpstart more people working on these issues, it would help a lot. And a lot of this has to do with data availability and accessibility. Sorry, I missed the last part of your question, or I forgot it.
Yeah, it was just, we can collect data, we can do all of this surveillance, but what about bridging the gap between the
Yes.
research and the implementation into
Yes.
policy?
So again, not a very satisfying answer, but I don't think you can plan for that very easily unless you can, as people who may be working in government, can, involve the sectors that are making the relevant policies and have some sort of involvement or attention of people who are working on inequalities, in people who are making policy, but policy is political. I think the expectation that there will be a link between surveillance and implementation is fine for levers you can pull that are not very political. It becomes less realistic that there's a one-to-one association when you introduce all the politics. And frankly, even if you told me you couldn't implement anything related to your surveillance, I would tell you we should still do it, because I think we need to know the society that we live in. And the way that that research and ongoing monitoring and evaluation plays out over time, we don't know. I mean, social movements can take up this information and use it to change policy and pressure governments. It's hard to know how your research or when your research or your, surveillance and monitoring will come in handy. And I think we should be okay with the fact that there isn't a one-to-one relationship with that. Not only do we need to be okay with it, we have to be realistic. I mean, if you had public policy and people who analyze and study public policy, they would probably laugh at the idea that you produce evidence and it results in change. It's just not how life works. So I think we have to know the place of what we produce. And I think it is important that we produce that. We are producing citizens in our classes who then become more aware. We're getting our stuff out to the general public, to government officials. And over time, you hope that a policy window opens and you can influence implementation. But I think we have to be willing to invest, even if we don't think we can change things tomorrow.
Perfect. Thank you so much. So we still have so many great questions, but unfortunately, we are nearing the end of today's seminar. So I would just like to take this time to thank you so much, Dr. Siddiqui, for sharing your insights and expertise, especially in this great discussion period. And thank you all for joining us today for the second seminar of the Surveillance Advances seminar series. We hope you enjoyed. So please take some time to complete the survey for this presentation. You can just scan the QR code on the screen to access the survey, or look for the link in an email that will be shared shortly. Your feedback, of course, is very important to us to identify areas of success and improvement for the series. And you'll also be able to request a letter of participation near the end of the survey if you need. And another reminder that the recording and the slides from this presentation will be available on the NCCID website in a few weeks. If you have other questions about surveillance advances, the seminar series, please visit NCCID's website at nccid.ca. Our next seminar will be held on Tuesday, November 28th. And that concludes today's seminar. Thank you all for joining. Thank you so much, Dr. Siddiqui, and we hope that everyone has a great day and the rest of a week.
Thanks so much.
Thank you.